Assalamu alaikum and a very good evening to everyone. This is Dr. Rida Islam giving you a very warm welcome in our another session of BCPS preparatory classes cohort 2 presented to you by Giving Back to Pharmacy in Pakistan. It's always a pleasure to see the consistent presence and keen interest of participants in our scheduled classes as Giving Back to Pharmacy in Pakistan has initiated this innovative and informative program for our young pharmacy professionals. We really hope and wish that these sessions will be helpful in our audience preparation for BCPS board exams as well as in their regular practice. Now, coming back to our today's session, as we all know that our today's topic is critical care that will be presented to us by our respectable faculty member, Dr. Ghulam Mujtaba. I want to give a brief introduction of Dr. Ghulam Mujtaba to our audience that he is working in Shaukat Khanum Memorial Hospital as Assistant Manager Clinical Pharmacy. His overall experience spans around 8 years in Shaukat Khanum Memorial Hospital. He has done his BCPS in 2017 and MPhil in 2018. His area of expertise are in critical care pharmacy, nutrition support pharmacy, acute care, oncology supportive care, and infectious diseases. Moreover, he has ASHP accredited preceptor in critical care and internal medicine. Now, I would like to welcome Dr. Ghulam Mujtaba in our today's session. Assalamu alaikum, sir. How are you?
अस्सलाम वालेकुम। मेरी आवाज क्लियर है मिस्टर?
Yes, sir. You are audible.
Okay, thank you so much to all the organizers, all the faculty members, and especially to the person who has made it possible for the second time that we are conducting this second cohort of training program for BCPS preparation. So today we are going to discuss critical care. So without any delay, because we are, we have a very limited time and we have to cover all the entire critical care topic in BCPS. So let's start.
Yes, sir. You may proceed.
Okay, so good. Thank you so much. So okay, so first we have a case scenario. A 62-year-old woman is admitted to the ICU for respiratory dysfunction. For respiratory dysfunction necessitating mechanical ventilation, her medical history is non-significant and she is taking no medication at home. Her chest radiograph shows bilateral lower lobe infiltrates. Her white blood cell count is 21,000, which is days. Lactate is 1.7, which is normal. Temperature is 103. Patient is febrile. Blood pressure is 82 systolic and 45 diastolic, which is normal. Normal for her is 115 systolic and 70 of diastolic. Heart rate is 110, which is a bit high. Patient is tachycardic. Patient has low blood pressure. Patient is febrile. Although the lactate is normal, but her white count is high. So respiratory rate is 22, which is also high. Patient is tachycardic, tachypneic. So after she receives a diagnosis of community acquired pneumonia, she is empirically initiated on ceftriaxone 2 gram per day and levofloxacin 750 milligram per day intravenously. After fluid recess with 6 liters of lactated ringer, her blood pressure is unchanged. So dopamine is initiated and titrated to 9 mics per kg per minute. So the people who who deal with acute care or critical care, they know the dosing of vasopressors are usually in microgram per kilo per minute or per hour. In most of the cases, they are mics per kilo per minute. So after starting dopamine, her blood pressure is 96/58, which is improved. Heart rate is 138, which has worsened. She has made less than 100 ml of urine during this last 6 hours, and her creatinine has increased from 0.9 milligram per dl to 1.3. Her serum albumin concentration is 2.1. Which therapy best suits for this patient at this time? So option A, uh, whether we should give 5% albumin, 500 mils intravenous over 1 hour, then we should assess mean arterial pressure. So whether we should initiate hydrocortisone 50 milligram every 6 hours, whether we need to change dopamine to norepinephrine or on doses of 0.01 microgram per kg per minute to maintain her mean arterial pressure above 65, or option D is to reduce the dopamine influence to 1 mics per kg per minute to maintain urine output of at least 1 mils per kilo per hour. So that is our first case for our first topic. So what is the right option in this case? What should we do? Patient, although after starting dopamine, the blood pressure has improved from systolic of uh, 82 to systolic of 96 and diastolic of 45 to 58, but patient tachycardia has worsened. Patient is in renal failure, which is quite evident from her labs, and uh, patient has a low urine output. So what should we do? So we'll come again to this case after discussing our first topic. So first, to understand the critical care and the concepts of critical care, we should know the hemodynamic parameters. So all of us, we know that arterial blood pressure is a product of cardiac output and a resistance to the flow, which is systemic vascular resistance, which we usually call SVR. So what is the cardiac output? The cardiac output actually is a stroke volume, is a product of stroke volume and heart rate. So this is a very important concept, and for our upcoming topics and our upcoming discussion, this is very important to know that what is blood pressure, what is cardiac output, what is stroke volume, and how they are interrelated. So blood pressure is a product of cardiac output and SVR, and cardiac output is a product of stroke volume and heart rate. So what happens when the stroke volume is low? Like in cases of trauma, in cases of hypovolemic shock, where the fluid, patients are intravascularly dry. So the stroke volume is less. So how does our body, our heart compensate for this? So through the release of catecholamines, by increasing the heart rate, cardiac output is compensated, and similarly the arterial blood pressure is maintained to uh, maintain the mean arterial pressure and perfusion of the body. So stroke volume is determined by preload, which is amount of the blood which is available to eject, and afterload. Afterload is resistance to ejection. It is the load which is available, or you can say you know which is against the pumping or the contractility of the heart. So afterload, usually SVR denotes the afterload, and preload the the amount of the blood which is usually intravascular volume. Preload is determined by the intravascular volume. So mean arterial pressure, how do we calculate mean arterial pressure? It is 2/3 of the diastolic and 1/3 of the systolic blood pressure. So normal BAP is 70 to 100, which is quite high range. 100 milligram is very really maintained. The newer guidelines or the newer SCC bundles recommends a mean arterial pressure of 65 and above in most cases. So preload is defined as a ventricular and diastolic volume, and it increases proportionally with stroke volume. So commonly used measures of preload include central venous pressure, pulmonary capillary wedge pressure, and pulmonary artery occlusion pressure. And newer measures such as stroke volume variation and pulse pressure variation. So these are the newer terms. For how do we calculate central venous pressure? So there are two ways to calculate the central venous pressure. One is to measure it through the central line, and in some hospitals they still have devices to measure the CVP, but the significance of CVP up with the newer evidence is uh, is a bit lagging. So CVP is no longer recommended for especially for septic shock patients. So pulmonary capillary wedge pressures, it is usually and PAOP, which is pulmonary artery occlusion pressure, they are usually determined by the Swan catheter. In some hospitals and some intensive care units, they are still putting Swan catheters, and they are measuring pulmonary capillary wedge pressure and PAOPs. Stroke volume variation and pulse pressure variation, they can be easily measured through the arterial line, which is a standard of care in most of intensive care units. So for all the patients who are hospitalized, who are ventilated in the intensive care units, they usually have arterial lines, and we oftenly correlate all these hemodynamic parameters with stroke volume and pulse pressure variation. So what is lactic acid? Uh, Lactic acid is, we know it is formed during the anaerobic metabolism, when there is not enough oxygen to carry out the aerobic metabolism. So in cases of hypoperfusion, lactic acid is the byproduct of the this Krebs cycle. So during stages of hypoperfusion, the tissue receives less blood and therefore less oxygen. If there is less oxygen for the tissues, they will use anaerobic metabolism with a subsequent production of lactic acid. So lactic acid is the measure of what? It's a measure of hypoxia. It's a measure of perfusion, uh, the perfusion level of the body. So lactate clearance can be used as a therapeutic endpoint in shock. So in newer surviving sepsis campaign, measurement of lactate uh, is a standard of care, and it has a high recommendation. So what we usually do, we all of our patients who end up in ICU with septic shocks, so we check lactate at very beginning, and then we continue to check lactate every 4 to 6 hours. Once it is clear, then it is no longer monitored. So what are the normal values? As we discussed earlier, systolic blood pressure is 90 to 140. Diastolic blood pressure is 60 to 90. Similarly, mean arterial pressure is 70 to 100. These are the normal values of heart rate and cardiac output, cardiac index, stroke volume. So for your exam point of view, you need to know the normal parameters. In some cases, they will give you the normal parameters along with the patient's values. But if they don't, you need to memorize these values, especially the common parameters. For example, you need to know what is the normal mean arterial pressure, what is the normal vascular resistance, systemic vascular resistance, what are the values of SVR, what are the values of heart rate. So similarly, what are the values of cardiac output, cardiac index. So you need to memorize these for your exams. So what are the types of shocks? So there are uh, 5 types of shock, 4 or 5 types of shock. One is distributive or vasodilatory, hypovolemic, obstructive, and cardiogenic. So what is distributive or vasodilatory shock? So patient with distributive shock usually have low SVR, low systemic vascular resistance early and late. For example, uh, septic shock is one of the cases, is one of the examples of distributive or vasodilatory shock. In all of us, we know in septic shock patients, they due to uh, due to extensive release of bacterial endotoxins, uh, they cause production of nitrous oxide. That nitric oxide uh, causes extreme vasodilatation and resultant low SVR. So similarly, at some stage, these intravascular capillaries, they become leaky, and the intravascular volume starts flowing from inside the vessels to outside into the interstitial space or into the extravascular space. So what happens, these patients would usually have low CVP, low SVR, and they would have high cardiac index due to increased heart rate. So what happens in hypovolemic shock? So cardiac index will be low because the stroke volume will be low, the CVP will be low, but the SVR will be high. So these are the cases where the excessive fluid from the body leaks out from the body, like in cases of trauma. When in case of major trauma, due to extensive bleeding, patients usually go into hypovolemic shock. So what is obstructive shock? Obstructive shock is, you know, uh, it usually occurs when there is obstruction between the pulmonary arteries or the pulmonary vessels. So usually it obstructs the flow either from heart to the lungs or from the lungs to the heart. So these are, usual examples. So the major causes of obstructive shock are massive pulmonary embolism or aortic stenosis. So the fourth type is cardiogenic shock. What happens in cardiogenic shock? Heart is not enough pumping, so cardiac index will be low uh, because the stroke volume will be low. CVP will be high and SVR will be high. So patient with cardiogenic shock have acute heart failure. Insufficient forward flow of the blood causes venous congestion and an underfilled arterial blood volume. So how do we treat hypovolemic shock? So as we discussed in our last discussion, the treatment of hypovolemic shock is fluid resuscitation. And second is patient may need vasopressors is if hypertension is not rapidly reversed with fluid resuscitation. So all those patients who have fluid refractory hypertension, they should be early started on vasopressors. So the efficacy of vasopressors is reduced in patients who have not received adequate intravascular volume. So how is that? How is that? Because when patient is intravascularly dry, if you give vasopressors, so what happens? For example, if you give noradrenaline, it is a strong vasoconstrictor. It will increase the SVR, so the blood pressure will increase momentarily. But what happens? The patient is fluid depleted, so there is not uh, you know their patient would usually have reduced preload, reduced stroke volume, reduced cardiac output, and reduced blood pressure. So the heart tries to compensate this low cardiac output by increasing heart rate. So that heart rate actually is, it's not the solution, but is actually it worsens the shock state, because the more rapid the heart pumps, the less time it gives the heart to fill itself for the ejection. So what happens? The patient would have low mean arterial pressure, patient will be hyperperfused, hypoxemic, and patients will have end organ damage. Similarly, it is very important that the adverse events associated with vasopressors, for example, arrhythmias and ischemia, as we discussed now, they are greater in patients who have not received adequate fluid resuscitation. So how to check the fluid status in these patients? So there are different ways and there are different uh, markers to check whether the patient is adequately fluid filled or not. If I tell you that in our hospital, there we use a number of methods to check the fluid status in these patients. So one way is to check the pulse pressure variation through the arterial line. In all those patients with which we can't put a central line arterial line in, then we can use the passive leg raising test. We can check the uh, which we can check the capillary refill time. Similarly, point of care ultrasound is another method where you put a ultrasound on the heart and you check the inferior vena cava, whether it is collapsed or dilated. If it's dilated, it means the patient is adequately fluid filled. But if this inferior vena cava is collapsed, it means that the patient is uh, fluid underfilled. So in all those patients, we give fluid, we keep giving on fluid until and unless patient is adequately fluid filled. So for the time being, when you are doing this, if patient has persistently low mean arterial pressure, please start all these patients on vasopressors. So how do we treat obstructive shock? So fluids and vasopressors, as we discussed, obstructive shock is a case where whether the pulmonary embolism or a cardiac tamponade or aortic stenosis is the actual reason for the shock. So how do we manage? So for the time being, you are going to reverse the primary cause. If the patient has low mean arterial pressure, so the sequence is same as we discussed in previous slide. You will give fluid, will give vasopressors, and till the time that we are going to treat the actual obstruction. In massive pulmonary embolism, what is the solution? Thrombectomy or thrombolysis. So how do we thrombolize? Through the use of thrombolytics. So if a patient doesn't have contraindication for the thrombolytics, so usually for thrombectomy, a vascular surgeon is required, which are, which is a major hindrance in these patients, management of these patients. Most of the hospitals, like in our country, we have hospitals where the vascular surgeons are not readily available. So the second option is to give these patients thrombolytics. So second reason, which is cardiac tamponade. So how do you treat tamponade? You drain the fluid. So what is a tamponade? What is a tamponade? So in tamponade, the 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 pericardial space, the it is a presence of fluid between your between the outer membrane of your heart and the pericardial space. So it uh, it prohibits or it inhibits the heart, or it reduces the heart pumping ability. And ultimately what happens, patient, usually these patients go into cardiac arrest. So what is the solution? You'll put a needle in, you'll drain the fluid from the pericardial sac, which is the only definitive treatment for cardiac tamponade. And if somehow this is not early diagnosed, or this is not early ruled out, patient, they end up dying. So now we have our first discussion on sepsis. So initially, in 2016 guidelines, they used to classify the sepsis syndrome into three categories: sepsis, severe sepsis, and septic shock. But in revised guidelines, they removed the sepsis because it was very confusing. So now there are only two categories: whether the patient has sepsis or septic shock. So what is sepsis? Sepsis is life-threatening organ dysfunction, which is caused by dysregulated host response to the infection. Remember, bacteremia or presence of infection does not classify the patient to have sepsis until and unless patients have life-threatening organ dysfunction. So what is the criteria to diagnose sepsis? So infection plus any two of the Q-SOFA points. So there are three Q-SOFA points. One is altered sensorium, if the patient has reduced GCS level. Secondly, if the patient has increased respiratory rate, which is 22 breaths per minute. And third is systolic blood pressure. So if the patient has established infection or very strong suspicion of infection, and patient has any two of these parameters, for example, patient is drowsy and patient is tachypneic, patient has increased respiratory rate, so this classify the patient to have sepsis. So what is the criteria inside the ICU? Patient has infection, which is uh, uh, whether we have a confirmed culture or we have a strong clinical suspicion. So whether the infection plus any acute change in the total SOFA score. For example, if the baseline GCS score was 15 and now the current GCS score is 13 or 12 or 10. So this is acute change. So infection plus any acute change in the SOFA score above 2 points classifies the patient to have sepsis. So it is septic shock. So it is a subset of sepsis where the uh, patients will have profound circulatory, cellular, and metabolic abnormalities. It put the patients on a high risk. It is usually associated with end organ damage or multi-organ dysfunction. So what is the criteria? If the patient requires vasopressors to maintain the mean arterial pressure, and if patient has lactate, which is more than 2 millimole per liter, despite adequate fluid assessment. So remember, whether the patient has sepsis or septic shock, at any point, if the patient has reduced mean arterial pressure, then the sequence of treatment is first you'll give fluid until and unless the patient is adequately fluid filled. Number two, you'll give vasopressors. So hallmark treatment of septic shock is rapid antibiotic administration, ideally within the first hour of hypotension. So this is the only recommendation which this is the only point which has a very strong recommendations and a very high level of evidence in surviving sepsis campaign, previous guidelines, new guidelines, and the guidelines which will be available in the future. So give antibiotics as early as possible, ideally within the first hour of hypertension. So SC recommends the following bundle for patients presenting with sepsis or septic shock. So 1 hour bundle. What is a 1 hour bundle? What will you do? Your patient is in triage, your patient is in ER. What will you do? You'll measure the lactate, you'll obtain the blood cultures before giving the antibiotics. But somehow, remember, this is clinically important. This is clinically, and this is important for your exam point of view as well. If you can't take the blood cultures within the first hour. Do not delay the administration of antibiotics, administration of broad spectrum antibiotics. You know, so these the administration of antibiotics has a mortality benefit in these patients. So do not delay the administration of broad spectrum antibiotics. Fourth, begin administration of fluids 30 ml per kg crystalline for hypotension or any lactate above 4 millimole per liter. So albumin can be considered when you have given a sufficient amount of the crystallites, but you know that the patient is still fluid depleted. But if you give more crystallite fluid, instead of increasing the intravascular volume, it will go into the extravascular space, or it will create the third spacing in these patients and will uh, exacerbate any pulmonary edema or any ascites. Or if the patient does not have ascites, it it will subsequently will cause pulmonary edema in these patients. So in all these patients where you can't give more crystallite, give albumin, because the albumin is plasma expander. If you give 5%, 500 ml of albumin, it will replace 500 ml intravascularly. When if we recall our previous talk in fluid electrolyte session, we discussed that if we give 1 liter of crystalline, 250 mils of the fluid will be available intravascularly and rest of the fluid will go outside the vessels and to the interstitial space. But in case of albumin, 5% albumin will be 100% replacement, and 25% albumin is a 5 times plasma expander. If you give 100 ml of the albumin, it will expand the plasma by 5 times. So what are the balanced crystallites? We discussed in in a detailed manner in our previous lecture. So if you have any question regarding the balanced crystallites or the benefit of balanced crystallites, we can discuss it in the answer and question session. So initiate vasopressor. If the patient is hypotensive after the fluid resuscitation or doing fluid resuscitation, start vasopressors to maintain the mean arterial pressure above 65, as we discussed. So what is the vasopressor of choice? The answer is norepinephrine. There was this one trial where dopamine was compared. It was it was randomized control trials. Patients were either randomized to receive dopamine or norepinephrine. So there wasn't a mortality benefit between these two, but the patients and dopamine group, they usually had life-threatening arrhythmias, and the 28 days mortality was high in these patients. So the initial vasopressor of choice is norepinephrine. So if the patient does not respond to norepinephrine, or the patient requires very high doses of norepinephrine, then you can add epinephrine. So vasopressin. So some organizations, there is very conflicting evidence and data available when we look at the choice of vasopressors. There are some hospitals, like in our hospital, if we have vasopressin, we prefer early initiation of vasopressors when a patient requires high doses of norepinephrine. So we start the patient on norepinephrine, and if the patient goes above 15 microgram per minute doses of norepinephrine, we usually start vasopressin. So uh, there are dosing errors associated with this drug because this is not a titratable drug. Uh, there is fixed dose regimen, which is 0.03 unit per minute or 0.04 unit per minute. So this vasopressin has no mortality benefit. The only benefit is that all those patients who receive vasopressin, they spend less time on vasopressors, they spend less time in the ICU. So there is no other benefit like mortality benefit. So dopamine, once this dopamine was treatment of choice for the treatment of septic shock, but is no longer recommended. Another thing which is very important to know, initially some clinicians, they used to give a low dose dopamine to increase the perfusion of kidney, but this practice is no longer encouraged, and this practice is not evidence based. So it is no longer used for renal protection. So vasopressin, I will not go into the details because we have a very limited time. So uh, as we discussed, initial vasopressor of choice is norepinephrine, and second one is epinephrine. So the dose, you can find it online or on the literature of the drug. Usually the dose is titratable dose, which starts from 0.01 microgram to 3 microgram per kg per minute. So the important thing is that you should know the the receptor activity of these drugs. So norepinephrine is a strong vasoconstrictor. It binds strongly with alpha 1 and then on beta 1. That is why when we compare norepinephrine with epinephrine or dopamine, norepinephrine has less chances of causing tachyarrhythmias. Right. Similarly, epinephrine. So epinephrine is alpha 1 agonist. It binds with beta 1 and beta 2 as well. So it has more beta activity. That is why this drug causes more tachyarrhythmias, and those tachyarrhythmias, they are they are life threatening in some cases. Similarly, vasopressin has a fixed dose regimen, which is 0.03 to 0.04 units per minute. So it causes the direct stimulation of smooth muscles by acting on the V1 vasopressin D receptors. So it is not titrated, it is a fixed dose regimen, and there is no benefit when we give it on higher doses than 0.04 units per minute. Phenylephrine. So most of the people, they are confused when they look at phenylephrine. Phenylephrine is a strong vasoconstrictor. It is not first line. We give it only for momentarily when we don't have a central line. For the time you put the central line in, then we switch the phenylephrine to norepinephrine. Phenylephrine has no beta activity, so that is why it does not cause tachyarrhythmias. So that is why in all those patients in which you cannot increase the doses of epinephrine, or altogether you can't start these patients on epinephrine because they already have high heart rate. So in all those patients, you can start phenylephrine as early as possible. So angiotensin 2, it's a there are very limited studies available for angiotensin 2. It binds to the G protein coupled angiotensin receptor type 1 on the vascular smooth muscles. So it increases the risk of thrombotic events. So this the more and more data is required to establish the role of angiotensin 2 in septic shock patients. Dopamine, as we discussed earlier, dopamine has dose related receptor activity. On very low doses, from 1 to 3 mics per kg per minute is usually has dopaminergic activity. It strongly binds with the dopa, but as we increase the doses, its alpha activity increases, so it becomes strong vasoconstrictor. Dibutamine. So dibutamine is like dopamine. Uh, so in all those patients who have in septic shock patient, remember, in in septic shock, at some point of time, patients have decreased myocardial contractility. They have ongoing myocardial infarction and cardiomyopathy. So it is called sepsis induced cardiomyopathy, and it is available on the literature. So dibutamine is usually started in all those patients where you are suspecting the myocardial ischemia or the decreased myocardial contractility, because it is strong beta 1 agonist, and it it also it causes beta 2 stimulation, and beta 1 and beta 2 stimulation. So that is why it is only recommended to give in the patients who have uh, concurrent cardiogenic shock along with septic shock. So milrinone is a phosphodiesterase inhibitor. It has no receptor activity, so it is a positive inotrope. The doses should need to be reduced in the patients who have ongoing renal failure, which they usually have. So role of antibiotics and their appropriate use in septic shock. So initially the patient should be started on broad spectrum antibiotics, considering considering uh, considering the pathogens, the likely pathogens that your patients might have. So common sources of infections in uh, in all these patients are lung, abdomen, blood, and UTI. So all those patients which have certain risk factors for fungal infections, uh, all those patients should be started on empiric antifungal therapy, either with the triazoles like fluconazole, or echinocandin, or lipid formulation of the amphotericin B. So what are the risk factors? So if the patient had recent abdominal surgery, if the patient had long-term parenteral nutrition, if the patient had indwelling central catheters or recent treatment with broad spectrum antibiotics, if the patient is immunocompromised, like the cancer patients or the patients who are on immunosuppressive medication, or the HIV patients who have very low CD4 count, all those patients, all these patients, they are immunocompromised population. So uh, so remember, you should know that before giving the empiric antibiotic, you should know the patient allergies. If the patient is penicillin allergic, obviously you have to consider the cross reactivity of the antibiotics that you are going to choose for these patients, and similarly susceptibility and resistance pattern in your institution. So consider empiric antiviral therapy with oseltamivir for patient presenting with flu-like symptoms during the flu seasons. So this is the initial case that we discussed in the beginning of our lecture today. So this lady presented with septic shock, and we when we started that patient on dopamine, initially the blood pressure increased significantly, but the patient had tachycardia, the patient had ongoing renal failure, so we had to pick another option. So the right option in this patient is to change the dopamine to norepinephrine. As we discussed, that norepinephrine is the initial vasopressor of choice. Patient is tachycardic, you can't give more dopamine, because maybe the blood pressure will increase with increasing doses of dopamine, but the patient will end up having life-threatening tachyarrhythmia. So that is why the dopamine should be changed to norepinephrine. So this is the explanation of this case scenario we have already discussed. So our very next topic is acid-base balance. So this is very dry topic. I'll try my best to explain it in a easy way and easy to understanding uh, way. But if you have any question, you can ask at the end of this session. So we have another case where a 62-year-old woman has been hospitalized in the ICU for several weeks. So her hospital stay has been complicated by aspiration pneumonia and sepsis. So she required prolonged courses of antibiotics. For the past few days, she has been having high temperature again, and her stool output has increased dramatically. Her most recent stool samples have tested positive for C. diff, and her laboratory test shows serum sodium of 138, potassium of 3.5, chloride of 115, bicarb of 15, albumin of 4.4, and pH of 7.3, PCO2 of 30, which is most consistent with this patient's primary acid-based disturbance. So option A is anion gap metabolic acidosis, non-anion gap metabolic acidosis, chloride responsive metabolic alkalosis, or acute respiratory acidosis. So this is very important topic और काफी मुश्किल है. अगर आप लोग सो रहे हैं तो प्लीज जाग जाएं, अदरवाइज ये बिल्कुल समझ नहीं आएगा और ऐसे ही बस सर से उतर जाएगा. तो प्लीज आप जरा जाग जाएं, और अगर कोई आपका सवाल है तो आप चैट बॉक्स में अभी लिख सकते हैं. ऐसा ना हो कि एंड पे आपको समझ ना आए और आप सवाल भी भूल जाएं. So what are the normal ABG's values? So we'll start with pH. So normal pH is 7.4. Range is 7.35 to 7.45. Partial pressure of CO2 is 35 to 45. PO2 is 80 to 100. Bicarb is 22 to 26 MEq per liter. And the saturation is 95 to 100. So how to establish the primary acid-base disturbance? What is acidosis? What is alkalosis? So any pH which is less than 7.35 or 7.45, it indicates primary acidosis, right? What is alkalosis? So any pH greater than 7.45 indicates a primary alkalosis. So remember, so your pH is maintained by two buffer systems in your body. You know, this system is very beautifully created by our God. So these two buffer systems, they are regulated by two organs. So we have two buffer system. One is carbonic acid and another is sodium bicarbonate. So carbonic acid is acidic in nature and sodium bicarb is basic in nature. So carbonic acid is regulated by your lungs and sodium bicarbonate is regulated by your kidneys. So what happens? So when the too much acid is present in your body, the pH will go down and pH will become acidic. So pH will go down below 7.35. So how does the body compensate? So the body tries to reserve the sodium bicarbonate through the kidneys. You know, sodium bicarbonate is alkaline in nature. So the body tries to compensate this. So this mechanism is called compensation in medical language, right? So what is metabolic disorders? Acidosis, as we discussed, in acidosis, there is decreased sodium bicarb. Alkalosis increased, you know, there is too much alkali present in your blood, which is alkalosis. In case of respiratory, the increased PCO2, which is, you know, acidic in nature. And in case of alkalosis, your body will lose CO2. So there are some, you know, medical conditions, like the patients with chronic obstructive pulmonary disorder. they are usually chronic retainers of CO2. They end up having acidosis. But how does the body compensates? The body conserves sodium bicarbonate through the kidneys, right? So what are the predicted degrees of compensation? So how this compensation is usually happening in the body? So this is a very complicated slide, and for the purpose of making this easier for you to understand, I'll skip this slide. If you have question, we can discuss it in a separate talk. This acid-base disorder is a very lengthy and a very complicated topic. And for your exam point of view, I'm sure they will not go into the details of physiology of acid-base disorders. Rather, they will give you a value and they will try to know that whether the primary acid-base disorder, whether the patient has metabolic acidosis, metabolic alkalosis, or respiratory acidosis, or respiratory alkalosis. So these are the steps. This slide is very important. If you if you come across a question in your exam, remember these steps. These steps are very important, right? When you are going to interpret the ABGs, remember these steps. First, you will assess the pH. Second, you will know the PCO2 values. And thirdly, you will know the bicarbonate values. So what is acidosis? If the pH is less than 7.35, this is acidosis. And if the patient has pH more than 7.45, that is alkalosis, right? So first, you have to establish whether the patient has acidosis or alkalosis, right? Now, the second thing which we discussed, first you will check the pH. Second, you will check the partial pressure of CO2. So if the partial pressure of CO2 is elevated, the primary disorder is respiratory, right? But if the PCO2 is decreased, the primary disorder is respiratory alkalosis. Third thing that we are going to check in the ABGs is bicarbonate, right? So for the bicarbonate, if the bicarbonate is decreased, the primary disorder is metabolic. And if the bicarbonate is too much elevated, the primary disorder is metabolic alkalosis. So I'll repeat this and once again. So what will you do? How will you interpret these ABGs? You will assess the pH. If the pH is less than 7.35, this is acidosis. If the pH is more than 7.45, this is alkalosis. The second thing is to check the PCO2. If the PCO2 is high, then it is respiratory. If the PCO2 is very low, then it is respiratory alkalosis. Third thing is bicarbonate. If the bicarbonate is decreased, the primary disorder is metabolic. But if the metabolic acidosis, but if the bicarb is elevated with increased pH, then the primary disorder is metabolic alkalosis. So another way to do this is to calculate the anion gap. So how you calculate the anion gap? You add the bicarbonate with the chloride, and you will abstract this from the sodium, right? So normal range of the anion gap is 6 to 12, and if the anion gap is more than 12, there is primary metabolic acidosis regardless of the pH bicarbonate. So this is very important formula. If you can't really memorize the previous slide, so this is a second step formula which is very important, so you can do this as well. So always try to interpret this anion gap carefully, because low albumin level it decreases the anion gap by 2.5 to 3 MEQ per liter. So if patient has low albumin which is less than 4, always remember to add 2.5 to 3.3 MEQ per liter in the original calculated anion gap. So the third step is to calculate the excess anion gap, which is total anion gap minus normal anion gap. You will you will add the excess anion gap to the serum bicarbonate. So what is the etiology? So this slide is very busy slide. You know, you will find these if you uh, look at any intensive care book, whether Paul Merino or any other book, you'll find these causes. Uh, so what is the primary acid-base disorder in this patient? So when we look at, as we discussed earlier, so firstly, we'll check the pH. So in this case, the patient has a pH of, so okay. So we'll go to the previous slides. Okay, so the pH is 7.35. So what is this? This is acidosis. The pH is less than 7.35. Second step is to check the partial pressure of CO2, which is 30, right? And third is to check the bicarb, which is 15. Now this is low, but not that much low. This PCO2 is low, but not that much low. So this bicarbonate is significantly reduced. So this is metabolic acidosis. The third thing is to know whether this is anion gap or non-anion gap. As we discussed, you'll calculate the formula and you'll know whether the anion gap is high or not. So what is this? So we discussed that the way to calculate the anion gap is to to add the chloride and the bicarb. So if you add chloride and bicarb, chloride is 115, you'll add it in the bicarb, so it will make it to 130. When you abstract this from the sodium, which is 138, so the answer will be 8. This is non-anion gap metabolic acidosis, right? So this is non-anion gap metabolic acidosis. So remember, in your exam, you may have similar sort of questions. So the way to interpret ABGs is very simple. So our next topic is cardiac arrest. So any pharmacist who participates in course should complete BLS and ACLS, both of them. So from pharmacy point of view, we should know the medications, how to give them, and the important role of these pharmacists is the medication administration during the cardiac arrest situation. So in cardiac arrest situation, the central venous administration of the medication is preferred, but somehow if the patient is very debilitated and the patient is intravascularly very dry, they cannot put a central venous catheter, whether the patient has any contraindication for the central venous catheter, or the patient is profusely bleeding, or any other contraindication, then how to give the medication during the cardiac arrest, right? So they can be given through a peripheral line, right? But peripheral line is a peripheral administration of medication is a very is not preferred somehow. So another way to give these medications is through the endotracheal tube, and there are certain medications which can be given through the endotracheal tube. Another way to give the medication is through the intraosseous route, right? So what is the post cardiac arrest care, right? Will not go into the details of cardiac arrest for time saving only. So when the patient achieves return of spontaneous circulation, right? What is this term? Return of spontaneous circulation. So if your patient had a cardiac arrest, so that patient will be pulseless, or or patient would have asystole, where the patient will not have any rhythm. So this is the time when the rhythm is back, when the patient has pulse, you know. So how to manage these patients? So remember, the post cardiac arrest care has a direct relation with in hospital mortality. So these interventions are very important to know and to execute in the intensive care units. So initial therapy is ventilation to maintain the oxygenation level of this patient, to maintain the blood pressure. Uh, and for that purpose, if you require vasopressor, you'll definitely start those patients. So as so the oxygen saturation should be maintained at 94% or higher. Insertion of an advanced airway may be necessary. All of these patients with cardiac arrest, they end up having uh, endotracheal tubes. So hyperventilation and excess oxygen delivery are harmful, and they should not be uh, done in these patients. Hypertension should be treated with fluid boluses and vasopressor if necessary. So another very important intervention in these patients is therapeutic temperature management, right? So this is one of the very few indications which this is one of the very few interventions which have resulted in improved neurological outcomes and post cardiac arrest care. So what is target temperature management? So you will induce hypothermia in these patients for 24 hours. You will start this as early as possible after the return of spontaneous circulation. And after the 24 hours, you will start the rewarming process in these patients. So as we discussed there, there is a benefit of increased neurological outcomes in these patients, in post cardiac arrest patients. But remember, there are certain complications of this therapeutic hypothermia, or you can say the targeted temperature monitoring intervention. So what are the complications? So when you start the rewarming process, patient will have, most of them will have shivering. So this shivering is not good for the patient. It will increase the metabolism. It will increase the oxygen demand of that patient, right? So how to manage the shivering? So there are certain medications like the sedatives that you can use to increase the risk of shivering. This is very important during the rewarming phase. So you can use propofol, you can use tramadol, you can use dexmedetomidine. So some, some institutions, they have proper protocol for this targeted temperature monitoring. So in all those protocols, they have a very documented uh, thing, or documented medications that can be used to stop the shivering. So similarly, paralytics are used to reduce or stop the shivering. But paralytics, they are associated with higher mortality within the ICU, and they should be used uh, for a very short period of time. And when the shivering or the therapeutic hypothermia, the rewarming has been achieved, they should be discontinued. Similarly, during the phases of hypothermia, the drug metabolism is significantly reduced, and similarly the distribution of the drug to the target sites is also reduced. So as a pharmacist, you should know that you have to give the bolus form of the drugs, and you have to reduce the continuous infusion dosing of these drugs. Similarly, when the patient uh, is started on the rewarming phase of this intervention, the drug metabolism increases, and you have to increase the doses simultaneously. Coagulopathy is also is a very important, or you can say a very serious complication of this intervention. And all those patients who have baseline coagulopathy, they should not be started on therapeutic hypothermia protocol. Similarly, increased renal excretion of water and subsequent volume depletion is also a complication. Arrhythmias and hypertension, hyperglycemia and hypoglycemia. So during phases, during the hypothermia, patients have hyperglycemia, and during rewarming, patients have hypoglycemia. So this hypoglycemia can be very life-threatening, and always remember to check uh, the uh, to check regularly the patient's blood sugar level when you have started the rewarming process. Electrolyte disturbances, one of them is potassium. So during hypothermia, hyperkalemia occurs, and similarly during hyperthermia, when you have started the rewarming, hypokalemia occurs. So our third important topic is pain, agitation, delirium, and neuromuscular blockade. Right. So the purpose of sedation in ICU patients is to minimize the agitation and to increase the endotracheal tube tolerance of these patients, right? So what are the general considerations in these patients? So non-pharmacological strategies to improve patient comfort include lighting, music, massage, verbal reassurance, avoidance of sleep deprivation, patient positioning based on the patient preference, right? So all of them, they are associated with improved outcomes. So determine patient goals using validated scales, routinely assess pain and sedation. Routine assessment of the pain and sedation should be performed in every patient in the ICU. So remember, the main reason of agitation in these patients is usually pain. So always remember to check whether the patient has pain or not. So there are certain limitations of uh, the pain management in critically ill patients are in the ICU patients. So we have two types of patients: the patients who are awake, who are oriented, and if you talk to them and you ask whether they have pain or not, uh, on a numerical rating scale, they will rate whether they have pain or not, and on what scale they have that pain, right? But in comatose patients, or in patients who have mental disorders, or who have central injury, or who have reduced conscious level, in all those patients, you patient cannot verbalize the pain or the magnitude of the pain. So in those cases, we use this BPS scale. So BPS scale has three items. One is facial expression, another is upper limb movement, and third is compliance with mechanical ventilation. So the total score in this BPS is is 12. So any the score cannot be 0. So the score of 3, if the patient is relaxed, if the patient has no movement, if the patient is tolerating the movement, the score is 3. It means the patient has no pain. So any score above 3 tells you that the patient has pain. So any score above 8 shows that the patient has severe pain, right? Similarly, RAS score, this is a very common scoring system which is used in intensive care units. So we have incorporated this RAS score into our HIS system. So for every intubated patient or ventilated patient, this is automatically calculated. So if the patient has RAS score of 0, it means the patient is alert and calm. There is no need to increase the sedatives or to add another sedative. So the more the positive score, the more patient is agitated. So any score above 0, like +1, +2, +3, and +4, this they shows that the patient is very agitated. And any score less than 0, -1, -2, -3, -4, -5, they all tell you that the patient is whether drowsy, has light sedation, moderate sedation, deep sedation, or patient is altogether unarousable. So goal sedation score should be individualized for each patient, but general score is 3 to 4, a SAS score of 3 to 4, or a RAS score of 0 to -1. So pain and discomfort, they are primary causes. So always try uh, to add a proper analgesia in these patients. So the approach is to use an analgeso sedative, the drugs which have analgesic as well as sedative properties. Morphine, fentanyl, ketamine, dexmedetomidine, all of these drugs, they have they are they have analgesic properties and they are sedatives as well, right? uh, so what are the dosing strategies? So they should be so try to remember that you must have a scoring system uh, for uh, for the target sedation score. So how to manage these patients? So remember, always try to assess the pain. If the patient has pain, uh, start all those patients on the analgesic. If the patient has still agitation and is not tolerating the tube, then start all those patients on proper sedatives like propofol, right? So bolus doses of these drugs, they are usually associated with hypertension, and in some cases this hypertension is very deleterious. So avoid bolus doses and increase the infusion doses. So in one of these guidelines, I studied that instead of instead of going to the maximum doses of a single sedative, try to add another sedative. Try to add moderate dose of two sedatives. you know so the purpose is to achieve the desired sedation level, and similarly to reduce the deleterious or the adverse effects of these sedatives. So benzodiazepines. So benzodiazepines, lorazepam is most commonly recommended, but benzodiazepines, they are associated with increased hospital stay, increased days on ventilation. They are no longer recommended there because of their increased risk of delirium in ICU patients. They are not the first line. Propofol is excellent drug, short duration, short shortest onset of action. You can easily taper from 5 microgram per kg per minute, and you can go up to 50 microgram per kg per minute. Remember, propofol related infusion syndrome usually occurs in patients who have high doses of propofol and has propofol for prolonged duration, right? So dexmedetomidine, it's a wonderful drug. It has replaced most of the first line drugs because it does not cause respiratory depression. It has analgesic effect and it is the initial choice. So there is one limitation, that you cannot go uh, go above 1 microgram per kg per hour of doses because of the risk of bradycardia. That bradycardia can be very dangerous in these patients. They all those patients in which you have uh, persistent bradycardia with dexmedetomidine. The answer is to stop dexmedetomidine and start those patients on another sedative. So delirium, which is acute change in cognitive function characterized by disorganized thought, altered level of consciousness, and inactiveness. So it is associated with increased mortality, prolonged length of stay, and cognitive impairment. So non-pharmacological interventions, they should always be tried first instead of pharmacological treatment, because pharmacological treatment has very adversities, has very lengthy adverse effects, are very serious adverse effects. So uh, always try to minimize the use of pharmacological treatment in these patients. But somehow, if you have to use, then the choices are haloperidol, quetiapine, olanzapine, risperidone, and ziprasidone. So we'll skip these cases because we have a very limited time. Uh, so preventing stress ulcers, right? So mucosal bleed is very common in critically ill patients. There are certain risk factors which put the patient at high risk of developing stress-related mucosal disorder in these patients. But at the signs of symptoms, patients might have hematemesis, gross blood in the gastric tube, aspirates. They might have coffee ground emesis or aspirate from the gastric tubes, or melena in most of the patients. Always put the patients on prophylactic therapy for stress ulcers in all those patients who have certain risk factors with developing stress-related mucosal disorder. Uh, so what are the risk factors, right? Uh, all those patients who require mechanical ventilation for more than 48 hours, and any of these risk factors which are listed below. For example, if the patient has ventilated for more than 48 hours and patient has coagulopathy, right? So always try to start those patients on regular prophylactic doses of stress ulcers. So what are the strategies? So we have only two choices. Either we can give H2 blockers or proton pump inhibitors. So ranitidine is out of the market. We have famotidine instead of ranitidine, but usually clinicians, they are inclined and they try to use PPIs more because of the very persistent effect. At once a day dosing is required, and uh, less uh, less you can say interruptions in the nasogastric feeds or the orogastric feeds are required for PPIs. So another important topic is pharmacological therapy for preventing VTEs, venous thromboembolisms. So what are the risk factors? So all critically ill patients, they are at high risk factors. Any additional factors may include recent surgery, major trauma, lower extremity injury, immobility, malignancies, sepsis, heart failure, respiratory failure, venous compression, previous VTs, increasing age, pregnancy, uh, all those patients who are on erythropoiesis stimulating agents, patients who are morbidly obese, patients who have central venous catheters. So all these are risk factors. And if the patient has these risk factors, start those patients on VTE prophylaxis. So if the patient has contraindication for the non-pharmacological therapy, right? If the patient has contraindication for pharmacological therapy, then always start non-pharmacological therapy, right? So in our ICU, we have a pneumatic tube, our compression devices, which are usually called Flowtron boots. Uh, so what are the choices for pharmacological management of VTE prophylaxis, right? So whether we give low molecular weight heparin or low dose unfractionated heparin, right? So they should be given with no prophylaxis. So in our practice, if the patient, we always give enoxaparin, but somehow if the patient has renal failure and require dialysis, so we switch low molecular weight heparin to the unfractionated heparin in all these patients. So preventing ventilator associated pneumonia. So the Institute for Healthcare Improvement has developed a ventilator bundle. So what is that bundle? So the head of bed elevation should be 30 to 45 degrees to reduce the risk of aspiration in these patients, which ultimately results into pneumonia, daily sedation interruptions, and assessment of readiness to extubate, stress ulcer prophylaxis, VT prophylaxis, daily oral care with chlorhexidine. Additional methods may include selective decontamination of the digestive tract, but data is very limiting. The studies are not suggestive of this practice, and this practice is very costly. So that is why it is no longer recommended. So we have our last topic. We have our last topic, which is intracranial cranial hemorrhage. So intracranial hemorrhage is a broad term that encompasses three terms. So one is interparenchymal hemorrhage, which is non-traumatic bleeding into the brain parenchyma. Another is, one is intraparenchymal, which is called IPH. Another is subdural hematoma. And third is extradural hematoma. So severity of ICH and resulting neurological injury. So commonly used scales for to assess the severity of intracranial hemorrhage is Glasgow Coma Scale. So this is a kind of a gold standard. There are certain other scoring systems as well, but this GCS score is a gold standard and is most commonly used in most of the hospitals. So in GCS, we usually look for three things: eye opening, motor response, and verbal response. So remember, GCS can't be zero. The minimum conscious GCS score is 3. So the 3 means patient is comatose, patient has no eye opening, patient makes no movement, and patient makes no sounds, right? The maximum score is 15, and the severity of ICH is intracranial hemorrhage is usually decided based on the baseline GCS score. So how to manage blood pressure control is very important. Hypertension should be controlled. You can look for the American Heart Association guideline for the management of aneurysmal subarachnoid hemorrhage in these patients. Similarly, so the blood pressure in all these patients, it should be slowly and gradually decreased, rather than a very rapid decrease in the blood pressure. So antifibrotic, in ICH you have to balance two things. If you do not treat the high blood pressure, the bleeding vessel will keep on bleeding. So ultimately it will increase the uh, ICP, intracranial pressure, right? And it will increase the mortality as well, morbidity in these patients, right? And somehow, if you reduced too much of a blood pressure, then uh, you you will remember that the perfusion pressure is solely dependent on the mean arterial pressure. So if the mean arterial pressure is too low, then the patient will not be able to maintain the cerebral perfusion pressure, and the patient will end up dying. Similarly, antifibrinolytic therapy is usually recommended. It should be given. Crash 1, Crash 2, and Crash 3 studies, they tell you that tranexamic acid in the emergency department in all those patients who receive tranexamic acid within the 72 hours, they usually have less morbidity and prolonged sequelae of morbidity as compared to those patients who do not receive tranexamic acid. So that is all for today's talk. And you can ask any question.
Thank you so much, Dr. Ghulam Mujtaba, for this informative lecture. We really appreciate that you bring your time and efforts for our class. So, as our lecture is ended, so it is requested to participants that if you have any query, you may ask directly on a screen, or you may direct message Dr. Ghulam for your questions.
So there is one question in the chat box. How to calculate the lactate concentration? So this lactate is a serum lactate levels, and there is a proper laboratory method to check the lactate concentration, and there is no formula to calculate the lactate. Actually, there is a laboratory method.
All right. There is one more question, sir. I guess it is regarding the very first topic. As the Sarvat Latif has asked that, are there any guidelines when we switch between phenylephrine and norepinephrine?
So as far as I know, there isn't particular guidelines. ये एक तरह के anecdotal experience हैं जिस तरह हमारे हॉस्पिटल में है. जैसे मैंने आप लोगों को बताया कि होता यही है कि जब आप सेंटर लाइन डालने जा रहे हैं तो when we look at the data, so extravasation severity is high in the patients who receive norepinephrine through the peripheral line. So if the patient has low blood pressure, and for the central line placement, it will take 1 or 2 hours for the entire arrangement of the procedure. For that particular period of time, you cannot allow the patient to have hypotension and ultimately hypoperfusion. That hypoperfusion can lead to end organ damage, and all those patients who have a baseline end organ damage in ICU, they have very high mortality. So that is why we start those patients momentarily on phenylephrine, and as long as we have a central line in, then we switch all these patients to norepinephrine. Another indication is where the patient has a very high heart rate, the tachycardia is very high, and when you increase the doses of second vasopressor, which is adrenaline or epinephrine, the patient might have uh, tachyarrhythmias, uh, ventricular tachycardia, or any type of other tachyarrhythmias. So that is a risk factor. For all those patients, we start low dose phenylephrine to maintain the mean arterial pressure above 65. I hope that answers her question.
Thank you so much, sir. There is one more question. How to check in shock patient that now they are fully hydrated before moving towards any vasopressor?
Very good. That is a very excellent question, and I tried to answer it during the lecture as well. So मैं दोबारा बता देता हूँ. कुछ मार्कर्स होते हैं जो बताते हैं कि पेशेंट हेमोडायनामिकली अब जो इंट्रावेस्कुलरली ड्राई है या इंट्रावेस्कुलरली फिल्ड है या नहीं है. उनमें से कुछ ऐसे होते हैं जिनके लिए किसी भी तरह की आपको इंटरवेंशन की जरूरत नहीं, किसी तरह के टेस्ट की जरूरत नहीं होती. उनमें से एक है कैपिलरी रिफिल टाइम. उस टर्निंग के ऊपर प्रेशर दे के रखा जाता है 5 सेकंड्स के लिए उसके ऊपर प्रेशर हटाया जाता है, तो आप देखते हैं कि रिटर्न ऑफ सर्कुलेशन कब होता है। अगर वो लेस देन 2 सेकंड्स है तो इसका मतलब ये है कि पेशेंट इंट्रावेस्कुलरली फिल्ड है। अगर वो मोर देन 2 सेकंड्स है तो इसका मतलब ये है कि पेशेंट इंट्रावेस्कुलरली ड्राई है। एक और टेस्ट है पैसिव लेग रेजिंग बोलते हैं उसको, ज्यादातर ज्यादा नहीं, कुछ कंसल्टेंट वो भी करके देख लेते हैं। उसमें ये होता है कि आप दोनों लेग रेज करते हैं। होता है ये कि आपके जो थाइज हैं उनके अंदर एक एडिक्वेट अमाउंट ऑफ ब्लड होता है जो पूल हुआ होता है, राइट। वो इफेक्टिवली उस सर्कुलेशन का पार्ट नहीं बन रहा होता या उस प्री लोड का पार्ट नहीं बन रहा होता। तो होता क्या है, आप लेग रेज करते हैं और वो लेग रेज जो है ना वो 10 सेकंड्स के लिए आप करके रखते हैं। तो स्टडीज बताती हैं और वो कुछ एक्स्ट्रापोलेटेड स्टडीज हैं जो बताती हैं कि ऐसे पेशेंट्स में 250 टू 300 का इंट्रावेस्कुलर वॉल्यूम रिप्लीट होता है। तो जिसकी वजह से 8 टू 10 मिलीमीटर ऑफ मर्करी इंक्रीज होगा इन द मीन आर्टेरियल प्रेशर। और अगर हो तो इसका मतलब ये है कि पेशेंट फ्लूइड रिस्पॉन्सिव है, उस पेशेंट को और फ्लूइड देने की जरूरत है तो आप फ्लूइड देते हैं। दूसरे जो टेस्ट हैं वो इंटरवेंशन के थ्रू होते हैं। उनमें एक आर्टेरियल लाइन आप डाल के चेक कर सकते हैं कि पेशेंट इंट्रावेस्कुलरली ड्राई है या नहीं है। उसमें पल्स प्रेशर वेरिएशन होती है, वो बता देती है। एक और होता है कि आप पॉइंट ऑफ केयर अल्ट्रासाउंड या फोकस उसको बोलते हैं, उसमें इंफीरियर वेना केवा को देख लेते हैं। और अगर वो पूरी तरह फिल्ड है तो वो फिल्ड है, अगर वो कोलैप्स्ड है तो इसका मतलब ये है कि पेशेंट इंट्रावेस्कुलरली ड्राई है।
Thank you so much, sir, for giving so much explanatory answers. We really hope that participants have cleared all their queries. It is suggested to participant that you may ask your queries in the WhatsApp group as we are running out of time. So, for a reminder, our next session will be of the topic with the topic of policy, practice, and regulatory issues that will be presented to us by our another respectable faculty member, Dr. Asif Awan, on Tuesday, 1st Feb 2022. Once again, thank you so much, Dr. Mujtaba, for giving us your time and contribution for our classes. We really appreciate your contribution, sir.
Thank you so much, all of you, to the organizers, to the team of Giving Back to Pharmacy in Pakistan, to the organizers of Academy of Excellence, and to all the participants, and especially to my colleagues in Shakat Khanam. You know, I have seen them in the lecture. So thanks to all of you. Jazakallah.
Okay, so for till our next session, take care, everyone. And thank you so much for being with us. Your consistent presence always makes our classes successful. So, till our next session, Allah Hafiz, everyone, and take care. Thank you.